Hi everyone, welcome to Ask the Egg Whisperer. If you're joining me for the first time and you want a question answered, go to asktheeggwhisperer.com, and that's where I pull all your questions for each and every show. We send you an email letting you know when we're going to answer your question, and then we even send you a link to the show later in case you couldn't watch it live. So thank you guys for joining me today, and we're just going to get right to your questions right now. So the first question is from Aura. Aura says, "Hi Dr. Amy, I'm 38 years old and my period stopped. It stopped January 19th, 2020. I'm irregular. Is it possible that I've started menopause? I would really like to have another child. What is your advice?" So Aura, it is so hard to be in this kind of situation. You don't know what's going on. Your period isn't coming and it's been over a year. So what I would say is test, don't guess. Get your levels checked. See what your AMH level is. You don't have to wait for cycle day 3. You can just do a random check. Random just means any day of the week. You can check an FSH and estradiol level as well as a progesterone level too to just see maybe you've ovulated recently. And then look at your AMH level too, and you'll get an answer. And the answer may not necessarily be what you were hoping it could be. Obviously, it would be really super if it could be something like, oh, your thyroid is off or your prolactin is up, or this might be PCOS. So you would know that if you should start looking in other directions by just doing these very simple blood tests. You can ask your doctor to order them for you and go to a Quest Diagnostics, for example. And then on today's Instagram feed, I posted something that I'm just going to share with you right now. And that's a mantra, right? I'm going to be a mother one way or another. And you're already a mother. And it sounds like you want to have a second baby. And, I actually said this earlier today. And it actually is quite timely that you should ask this question because then I can share this with you. And then I said to a patient of mine today, and I said, you're going to find a way, even if it's without your own DNA. Okay? So I know that sounds like kind of like why would I even consider that? But I feel like if you truly want to be a mother again to another baby, then sometimes when we run out of healthy eggs, which happens to 100% of us, every single one of us will run out of healthy eggs. Believe me, 100%. There's no such thing as if you believe it, you will achieve it, and that means growing more eggs. I wish it was as easy as that. So sometimes we have to start thinking about other options before we are ready to, and sometimes we're made to feel like if our eggs have run out, that means our desire to have a baby goes away, but the reality is that actually is not true and does not happen for a lot of women. So this next question is from Marcia. Marcia says, I'm 42 years old, my AMH is 4.5, my FSH and LH are normal. I've been taking CoQ10, D-chiroinositol, folate, omega-3 and 6, and vitamins A and E. I'm also taking thyroid medication for my thyroid. All the vitamins in my thyroid medication were started shortly before the last egg retrieval. I've done 2 egg retrievals now over a 6-month period. Both times, no eggs were retrieved. My doctor believes it could be poor quality eggs. My question is this, what could be done differently during my next IVF cycle? So Marcia, that's a really hard thing to hear. You wake up from the egg retrieval and there are no eggs. So that's what I call an IVF challenge. So you are clearly challenging your doctor to think creatively and think outside the box. And so if they're not doing that, it's time to find a doctor that will for you. So it's very, very rare to have empty follicle syndrome. Extremely rare. It is a genetic potential issue, but it is so rare that it is almost unheard of to actually happen, but it can be a thing. So my recommendation is to look at the trigger shot time relative to when the egg retrieval is done and see if that can be optimized. Take a look at the trigger shot dose that you were given and see if that could be optimized. Ask your doctor, should I use a different form of a trigger shot? Should I also be triggered at a different time? Perhaps your eggs weren't mature enough and you should be triggered at, let's say, 37 hours before your egg retrieval. See, those are all the different things that you can consider doing. So be sure to talk to your doctor about that before you go into another cycle. And at 42, it is, as you guys have heard me say, it's hard to find a good egg. And if I have a patient who, let's say, has 5 or less eggs and they are, let's say, 42 years old, I sometimes have to tell them I might not get a good egg, meaning like even a mature egg from this batch. And that's nothing to do with me and my abilities, but it might have to do something with egg viability. So it might be a sign that it's time to start to look in other directions and look at other options to grow your family. But if you still feel like you have one more cycle in you, maybe talking to your doctor about the little things that I just mentioned could be helpful. This next question is from Lee. Lee says, "Hi, Dr. Amy. Thank you for your informative show and creative approach to fertility. You're a gem. I heard you mention on a previous show, number 271, I'm flattered by that, a protocol for high-dose Femera and other stim meds to get 4 to 5 eggs to ovulate. I'm hoping you can share exactly what medication doses you recommend. I turned 44, I have one living child, aged 2 years, and another one who passed away, both without fertility drugs. We've done 2 IVF cycles without success, and we're prepared to go to donor. But I heard you mention this protocol, and we could try without IVF, and this may be our last shot at having a biological sibling for our son, and this is important since our oldest passed away. Can you provide details so I can ask my RE? Would we need to do IUI, or could we try to conceive on our own? I get pregnant easily. 3 miscarriages, 2 biochemicals, and my husband's sperm is good. We've done all testing possible. My age and egg quality are the issue." So Lee, in a case like yours, I would actually consider using HGH, even if you're not going to do IVF again. I would track and trend your follicle numbers and your hormone levels. And if you have like an amazing cycle where you're like, wow, where did all these eggs come from? Perhaps you actually decide to go and do IVF if a cycle like that comes your way. So I always try and give my patients the best chance of pregnancy with each cycle. And I always say, in a case like ours, because I have lots of patients who are 44 in your situation, I say this, look, let's just be open to all possibilities in this cycle. Let's be as aggressive as we feel comfortable being, and then we'll learn if this should be an IVF cycle or IUI cycle. So sometimes I even have patients take medications like ganirelix in an IUI cycle in case we want the option to switch over and be ready to do an egg retrieval if the eggs are like sparkling and talking to us. So the protocol that you could use is the high-dose Femera, anywhere from 3, and I've even gone to 5 pills per night. All the Femera doses are the same, 2.5 milligram pills. There isn't a different dose. And then depending on the number of follicles and when your doctor could see you next, you also add in, let's say, about 300 units of a gonadotropin like Menopur or Gonal-F. And then 2 days later, you would go in for another ultrasound. And depending on how many follicles you see, you might add a little bit more medication, like maybe 150 units gets you up to 450, but that really depends on what you're seeing on ultrasound. Adding the antagonist when your follicle size is around 14 millimeters, and then triggering, and consider triggering with HCG and maybe even some Lupron. Potentially, that could help. So that's a strategy that I've used before in patients. It's kind of like a mini IVF approach to get a maxi number of eggs. So I like saying that a lot. I don't know why it sounds fun. Okay. This next question is from Cynthia. "Hi, Dr. Amy. Thank you so much for taking the time to answer my question. I'm 35 and I had my AMH levels tested when I was 34 6 months ago. It came back at 0.25 and we tried a cycle of IUI and I was told that I had 3 follicles growing. My husband has no issues with the sperm, but the IUI didn't work. My doctor recommends doing IVF. However, that's really out of our budget and we're not able to right now. Would you recommend attempting IUI a few more times, or should we try to figure out how to raise money to attempt an IVF cycle?" Okay, Cynthia, so my recommendation in your situation is do what you can to do IVF. The fact that you have a fertility doctor that is like rallying and super excited to help you means everything. So your doctor believes in your IVF success. Your doctor believes that it's worth it for them to do IVF for you. I can tell you, not everyone is like that. You know, there sometimes are doctors, and I hear stories like this often, but I can tell you that most of us would rally around a 35-year-old with an AMH of 0.25 and give you every opportunity to do IVF. But sometimes doctors can be discouraging and make you feel like it's not worth it for them, or you don't have enough follicles for them. So I would do what you can to do IVF. Take my IVF class. Empower yourself with all the stuff that I talk about in my IVF class. You can go to eggwhisperschool.com to sign up, and hopefully you'll learn all my little tips and tricks to take to your clinic, and you'll just be wowing them with all the knowledge that you have about PGT and what you see on ultrasound. Every time you go in, you'll ask questions like, what is the size of my follicles? What's the protocol I follow up from now? When's my retrieval going to be? And they're going to be like, wow, you really know your stuff. Okay, this next question is from Kristen. Kristen says, how many days after IUI would you recommend having intercourse and at what frequency? Every day or every other day? Also, I started progesterone suppositories. Do you recommend a way to insert without an applicator, and can you still have intercourse while using them? Kristen, great question. So after IUI, this is what I do with my patients. I basically have told them what the sperm looks like. And if the sperm is like, I'm like, have sex at least once in the next 24 hours. If the sperm is like, ding, then I say, listen, sex is just for fun, not recommended or required, right? And then if the sperm is like, super bad, then I'm like, go home, have sex. 2 hours later, have sex. 2 hours later, I'm just kidding. I actually don't say that. I give people honest and transparent information about their expected outcomes, especially with IUI, because I feel like if the sperm it's not a good sperm day and it doesn't work, I would want to know if it were me. I would be super upset if I had all these hopes and then it didn't work and then someone told me, well, I didn't really expect it to work anyways, right? That's not cool. That's kind of mean. And so I always want my patients to know what the sperm look like. So ask your doctor, be like, what does the sperm look like? Do you think we should have sex? And if you want to have sex, if your body is like, have sex, listen to your body and have sex. But I don't necessarily recommend IUI sex after IUI. I totally recommend IUIs. I'm not an IVF only kind of doctor. But I always tell my patients, have sex for fun, right? It's not for making a baby after the IUI, because I try and time my IUIs as perfectly as possible. So sometimes I tell patients to have sex that night and the next day, but for the most part, that's about the limit as to when you should be having sex. Okay, I had a joke in my head, but I don't think I can say it because it's not proper. Okay, it's a funny one though. As far as the progesterone suppositories and how they're used, without using an applicator, you can actually just use the tip of your finger. It's as simple as that. And if when you place it vaginally, it makes you feel kind of itchy and uncomfortable, that's kind of normal. So these capsules, these progesterone capsules that we place in our vagina, I call it pharmgina. Get it? Like pharmacy in the vagina? There should be a website, pharmgina.com, and actually, yes, I do own it. I don't know what I'm going to do with it, but one day I'll sell applicators so you can use these pills more easily than using your finger, because that's not so comfortable for everybody. But you can actually buy an applicator online. So Amazon sells applicators for pills like this. So you can actually not use your finger if you're not comfortable using it. But for my patients who are not comfortable placing the progesterone in the vagina, no problem. They're actually made to be swallowed. When you swallow them, what happens is you can feel a little bit drowsy, a little bit down, maybe, feel a little, I call them the blues, post-ovulation blues, and progesterone can definitely cause that. So when you place it vaginally, you're less likely to feel that bad. So okay, this next question is from Gina. Gina says, Happy New Year, Dr. Amy, and thanks for answering my previous question. I mentioned that my first transfer didn't work. I transferred a normal 5BB embryo with the second biopsy. My question is, what protocol would you recommend for my next transfer? The reason why I'm doing IVF is this. I have a translocation and I had a uterine septum which was removed. Even though when I had a saline sonogram, they saw a remaining 8.6 millimeter septum, they suggested not to do another surgery. I only have 2 more embryos left, a 6BB and a 5BC. Which one should I transfer next? I had a stimulated transfer protocol with suppositories that included progesterone, estrogen, and Viagra. And my ultrasounds, they told me that my uterus lining was thick. I would appreciate your advice. Gina, don't transfer. Do another hysteroscopy and have that septum removed as much as you can. You only have that one embryo, 6BB, that really will give you at least, I think, a 50% chance of pregnancy or more. The 5BC isn't as good quality, but still, I don't want you to look back and wish that someone had told you this. So I'm going to tell you this. Remember, this Ask the Egg Whisperer is just basically educational, informational. Don't confuse it with medical advice. So I'm just going to educate you that sometimes even with a little bit of a septum, that might be a little bit too much for an embryo to grow in the way that you want it to grow. So I don't want you to have any more implantation issues. Let's do another hysteroscopy and get the remaining 8.6 millimeter septum out. That to me is a little bit too much of a septum to keep there before your next transfer. Okay, this next question is from Rashmi. Rashmi says, Hello, Dr. Amy. I've been trying to conceive for the past 1 year. I'm 30 years old. I did my follicular study and my doctor prescribed me for Clomid for 2 cycles. It was painful after ovulation. I didn't conceive. I would like to understand the alternative medicine which I get online and the quantity. Also, he never gave me progesterone medications for any of the cycles. I did not get any appointments for the next 2 months. I changed my fertility doctor and now there's no availability. I'm on my own feeling depressed. There is no issue with my uterus or eggs. Can you tell me what else can I do aside from Clomid and progesterone? Excuse me. I'm taking prenatals and also folic acid. Okay, Rashmi, give me a second. I'm going to drink out of my Dr. Amy mug right now. So, this is the thing, Rashmi. Clomid is evil. You heard it here, you guys. I mean, I'm joking, but kind of not really. I know a lot of people can take it and they tolerate it really well, but I actually feel like it's a medication that has lots of side effects. I prefer a different fertility pill called Femera. That's the brand name. Letrozole is the generic name. It's about, I think, anywhere from like $3 to $10 a tablet, depending on which pharmacy you go to. So I think it doesn't thin out, not I think, I know it doesn't thin out the lining the way that Clomid can. It doesn't make us feel like we're losing our mind the way Clomid can, although maybe 1 out of 20 patients will feel like it could be like causing the devil to come out of them. I have heard patients refer to letrozole Femera even as the devil pill. So I don't want to minimize or make you feel like if you took Femera and felt horrible that, you know, there's something wrong with you, because there isn't, because sometimes you can feel horrible on Femera too. So all these drugs can affect your mood and make you feel pretty darn snarky. As far as progesterone goes, I recommend it to everybody unless you have really bad side effects from it. And if you do, that usually means that your natural progesterone levels are already pretty high and you don't need it. But I recommend progesterone 3 days after ovulation for all my patients who are trying to conceive until their pregnancy test. And with a positive pregnancy test, they continue the progesterone until they're about 10 weeks pregnant. And I do monitor HCG and progesterone levels really frequently in pregnancy. So if I find that the progesterone levels are really high, let's say, you know, way over 20, then I'll say, you know what, I don't think you need the progesterone anymore. And we feel pretty comfortable about stopping it. This next question is from Ella. Ella says, I have 2 polyp size 0.6 and 0.5 centimeters. I've done 2 IUIs with no success. Could these polyps be causing the failures? My doctor does not seem concerned about the polyps. Thank you. So Ella, this is the thing. You've already done 2 IUIs with them. Enough's enough. Let's just get them out, put them in a jar. We name our polyps around here. We call them Polly the polyps. For anyone whose name is Polly, I'm sorry. I know. I hate it when I hear names for products or I say something and then someone's like, well, my name's Polly. I'm like, sorry. So all the Pollys out there, don't take offense that I'm calling polyps Polly the polyps. And I'm saying you belong in a jar. You don't really belong in a jar if your name is really Polly. But the way I think about it is a polyp is like almost Mount Everest to a little embryo that's traveling down that fallopian tube. Or you can think of it as like, you know, that show Wipeout, you know, when the human obstacle course where you're going through stuff. And if you think about a sperm trying to swim up into a uterus and it sees that 0.5 millimeter or centimeter polyp, the sperm will be like, I'm not going past that. And they can't get into the fallopian tube, right? And then alternatively, the egg and sperm, when they meet in the fallopian tube, that embryo, as it travels down into the uterus, it may not be able to find a little space to like wiggle in and stick and grow. So I would talk to your doctor and just say, hey, can we talk? Can we schedule me for a hysteroscopy, please? I'm wondering maybe with COVID, it's just not so easy for them to do these types of procedures. So perhaps ask your doctor if that's the reason why they're not encouraging you to do it, if they don't agree that you should have it done again. Okay, this next question is from Gina. Gina says, hi, Dr. M.A. Your name is beautiful in French. Yes, thank you. I discovered you, not thank you. I mean, you're telling me what my name is in French and cool. Okay, I discovered you a month ago and I'm already a big fan. Trying to conceive for 1.5 years now after a long breast cancer operation and radiotherapy treatment. Before my operations, I tried to conceive as well, but the oncologist said it was better to remove the tumor first. Well, here I am now, already 44, and I've done all the tests. Hsg, everything you name it, etc., and everything is okay, but I have low AMH. It's only 0.3 and my FSH is 19. My question is this. My doctor put me on Ovidril since I had an 18 millimeter follicle, but it didn't work. Could that be since he told me I only should use 1/4 of the real dose of the injection? I feel like I have quite big follicles and now he wants me to try Gonal-F for 3 days and then another medication. And do you think it's a good idea, or should I try again with the Ovidrel but putting in the right dose? He says we can try IUI but not IVF because of my age. Okay, Gina, back to the first thing that I brought up at the beginning of this show. I really think you're going to be a mother one way or another. And it's going to be okay if it's not going to be with your own DNA. It's really hard to find a good egg at 44 for anybody, even someone who hasn't gone through what you've gone through with the breast cancer treatment. I want you to spend your youth. You're 44. You're young. You're young to me. You're younger than me. Being a mom, not a fertility patient. So I would really start thinking about creative family building options. Talk to a therapist and kind of just talk about all the emotions and all the options, and then figure out what feels the best for you. And I always say also to my patients is hope never hurt anybody. But hope really means having only practical and positive expectations. And practical in your case would be really understanding what the true chances of pregnancy would be. Whether you take a quarter of a dose or a full dose of the Ovidrel, I don't necessarily think that's going to make a big difference in your outcome. It sounds like your doctor is trying to be creative and give you a really good chance and be as aggressive as possible, and I'm totally on board with that. But I would say if you guys are not successful by, let's say, next 3 months, perhaps move forward with a new plan that will give you the family that you always wanted. Okay, this next question comes from Hershey. Hi, Dr. Amy. This is Harshita, and I'm 30 years old. We've been trying to get pregnant for the past 3 years with no luck. Every cycle ovulation is really the issue. Here's what happens. Each cycle, I spot for a week before flow starts. I was put on 2 Clomid and 3 letrozole cycles with letrozole 7.5 milligrams. I ovulated on day 26 of my cycle. I was later diagnosed with mild PCOS and unexplained infertility. My doctor is saying to go with IUI with letrozole, 7.5 milligrams, and progesterone. What would be the reason for someone like me to have anovulatory cycles every month? Does that might mean I might never ovulate on my own? Would IUI help with the letrozole, or would it help if we go with higher doses, since last time I used 7.5 milligrams and I ovulated on day 26? Please provide your thoughts. Thank you so much. Hershey, the way I think about PCOS is this. Please confirm this ovary syndrome. Okay? So what's the evidence? What tests have you had done? Have you had an AMH done? And the reason why that's really important is I see this, unfortunately, even today, I see patients being labeled as having PCOS when they really have decreased ovarian reserve. You expect them to have an AMH of over 3, and they end up having an AMH of 0.3. So get all your official reports, do a complete PCOS workup, and let's heal, H-E-A-L, your PCOS. Let's look at all the labs and see what we can do to balance your hormones to give you the best chance of responding to your medications. It sounds to me like your body might be a little resistant to these ovulation induction medications, and that is extremely normal in women who have PCOS. The strategies I use in cases like yours would be to go up to 10 milligrams of Femera, so that's basically 4 tablets per night for 5 nights. Sometimes I even extend that to 10 nights. Yep, that's a protocol as well. I also add in additional medications like naltrexone and dexamethasone starting at the beginning. And I also talk to my patients about taking PCOS supplements like ovasitol, lipoic acid, and acetylcysteine, all 3, along with CoQ10 and, prenatal, vitamin D, and fish oil. So those are the things that I think that can be really helpful in your case. You can consider adding them. And whether you do IUI or not, I don't know that it's really a big deal that you add it, but sometimes when you've already gone through everything that you've gone through, it makes sense to do both. Have sex leading up to the follicle check right before your IUI, and then still do the IUI procedure. So I wish you all the best. I hope my tips are going to help you, and I want to hear back from you too to see what happened. Okay, this next question is from Vicky. When do you advise your patients to stop DHEA NAD pterostilbene? I'm going to just show you what pterostilbene is. This is what it looks like right there. That's how it's spelled. Because sometimes I say things on here and people are like, I didn't understand what you were saying. And I totally understand why you wouldn't understand, because it's like a funky word that starts with a P. Okay, so back to your question. Before stimming or at egg collection? Thanks. Vicki, great question. So I tell my patients, so you have to ask your doctor what your doctor will do. I say take them through egg retrieval, and then let's see what we get. And if it's like, we are done, then you can stop. So I even have patients take it up until the egg retrieval day, and sometimes we just want a break. It's like, enough is enough from all these pills. Give me a break. So I tell my patients take a break until we know how many normal blasts we have, and then we get back on them if we're considering embryo banking. There are doctors, however, who have a very strong opinion about not taking the supplements for different reasons up until while you're stimming, because they're worried about bleeding excessively. Maybe some of these are blood thinners. I know exactly the equipment that I have, the gauge and the needle that I use, and I'm very, very lucky. I feel I should knock on lots of wood that I haven't had any bleeding issues in all these years for patients who stay on their medications, meaning the supplements that you're referring to, up until the egg retrieval day. But talk to your doctor about that. Very good to do. This next question is, this is a good one, I'm not sure. Does resveratrol lower DHEA? I actually don't know the answer to that. Therefore, if you're on both of them, do they work against each other, or does the DHEA compensate for resveratrol lowering DHEA? Vicki, I'm not aware of any studies that have shown that resveratrol lowers DHEA, but now I'm super curious and I have to look it up, and I will later. Thank you for that. Okay, this next question is from Janelle. Janelle says, hi, Dr. Amy. Your show is the most enjoyable source of information surrounding fertility there is. Thank you, Janelle. I appreciate you saying that. Thank you for being ultra informative, yet hilarious during this difficult journey. I'm glad someone thinks I'm hilarious. Not many people think I'm that funny. My husband and I are 30 years old and struggling with secondary infertility. I have cystic fibrosis and make very little fertile cervical mucus. I have a 3-year-old conceived naturally. Fast forward, my HSG and internal ultrasound were normal. My AMH was 1.65, and my clinic never tested FSH or did an AFC. My hubby has a robust, we call that sparkling, sperm count, some where he's high-fiving himself, with normal motility but a morphology of 3.5%. We've done 3 rounds of timed intercourse with letrozole, 2 letrozole IUIs with trigger, and progesterone support with 1 chemical pregnancy. We are about to begin IVF. Is that the right step? I've also been given a new diagnosis of RA, which is rheumatoid arthritis. What research is there about CF and autoimmune disorders affecting fertility? Should I ask for an immune protocol? So, Janelle, you guys know that I have something called the Angel Method or Angel Workup. So it sounds like you've done some tests already to reveal this RA diagnosis. So what I'm wondering is if you've done other autoimmune tests, looking at antiphospholipid antibody syndrome, for example. So I don't want to start looking at things that aren't as obvious as the things that are right in front of us and can cause, let's say, a miscarriage more commonly than other things. And then I also don't want to miss the opportunity to give you the best advice around what might truly be the fertility issue. It sounds like there is I'll just put it in air quotes, a fertilization issue. This fertilization issue could be egg-driven, sperm-driven, or both. When I see the sperm morphology at less than 6%, I always want to know more about the sperm. I want to know more. I want to give you guys the best chance of getting pregnant without IVF. So how do we do that? So we learn more about the sperm by doing the sperm DNA fragmentation test. You can go to the scsadiagnostics.com website. Anything that I recommend, I have no business relationship with them, nothing at all. I'm just sharing easy ways for you guys to get this testing done without a doctor's order. So you can go to that website and you can download referral without a doctor's order, and they'll ship you a tank. You do the test, you send it back. If the sperm DNA is good, then I would say all clear for IVF and consider doing ICSI since the morphology level was low. In my patients, I also add other things like Pixie or Zymont that can sometimes help with a healthier, I'd like to think, a healthier sperm choice and better fertilization rates and higher quality embryos. I really wish it would happen like that every single time, but I feel like if there's anything I can do to give my patients the best chance, I'm going to do it. Looking at your husband's testosterone level, his supplement levels, not supplement levels, but supplements that he's taking, looking at his sleep and his stress, like all of those things are super important for both of you. And then I would say once you've done embryo creation, I would say look really carefully at your uterus just because you had that biochemical. It sounds like you've done the tube test, so it doesn't seem like that could have been an ectopic pregnancy. Look at the genetic stuff. We already talked about the sperm DNA fragmentation test, but also think about doing carrier screening. And it sounds like you guys already probably know that he's not a carrier for CF. But also look at other things like thrombophilias, like factor V Leiden deficiency, or if you are heterozygous for that. And then the other thing would be to look at a chromosome analysis for both you and your husband. So before you make this very serious, big decision to do IVF, especially when you've had one biochemical, it makes sense to look at all of those things. And then when you transfer, you're going to feel like, I can let it go. I've done everything that I possibly can. And make sure that your RA is well managed. I have definitely transferred in patients who have RA. I've managed their cycles with the use of steroids and in conjunction and in collaboration with their rheumatologist. So in a case like yours, I would always defer to the expert in that disease. So if it's we're dealing with RA, I'm going to talk to the RA specialist and make sure that we're on the same page about all the medications that you're taking before we transfer. Sometimes I even consider drugs in cases like that, like Lovenox, which is a blood thinner. Some people would say it's not really that necessary, but other people would say, hey, Amy, I agree with you. Why not just take it and then we can always stop it once we see the heartbeat? Okay, so this next question comes from Erica. I'm 32 years old with an AMH of 2. My doctor says that's low. I'm starting my first IVF cycle and I was put on birth control pills for 14 days. At my baseline, I had a 22 millimeter cyst. My doctor wants to try my next period without birth control. Would it be better to start the next cycle as a natural cycle, or should I ask to be on birth control longer and then see? I know cysts are common, but I'm wondering if my body just doesn't like the pill. Erica, that is a really great observation, and this is the deal with cysts when you're on birth control pills. The deal is this: the birth control pills that we use nowadays are not super high dose. In the old days, like, 20, 30 years ago, the birth control pill doses were super, super high, so it's very, very rare that anyone would ovulate on them. But they were so high that a lot more people would have blood clots and other complications from them, but not nowadays. So what you could do is look at the strength of the birth control pill that you're on and perhaps ask your doctor to use one that's a little bit stronger. That could help prevent another cyst from forming. And at the same time, I'm hearing some discordance between what you're doing and what you're hearing. What you're hearing is that your egg count is low, and what you're doing is you're taking birth control pills, which can lower the egg count. So perhaps bring up this concept of a natural cycle start. I totally advocate for that in a case like yours, to give you the best chance of pregnancy and to hopefully just ride the wave of eggs as soon as they come before another cyst does. Think of the cyst as the shark in the water. Shark! Yeah, cysts are the bane of my existence. When I'm ready to start a cycle, I'm super excited and I'm just like, why are you there? You're getting in my way. I don't have time for cysts. Almost never do I have time for a cyst. This next question is from Deanna. Deanna says, hi, Dr. Amy. Thank you so much for your show. It's been so helpful and positive in a difficult and confusing time for us. I'm 35 with PCOS, and I've struggled with irregular cycles between 45 and 60 days, acne and hair growth. I have a normal BMI, normal thyroid, normal glucose levels. My AMH is 7.66. I've been able to control my symptoms without birth control, which I've been off of for over a year, and have shorter cycles now, 35 to 40 days. And when I take DIM or DIM, I'm going to butcher the name, so it's I'm going to butcher it, so I'm not even going to try it. My doctor's not familiar with it, and I'm unsure if I should be taking it while starting fertility treatments. I'm starting my first round of letrozole Ovidril with timed intercourse with my next cycle. So this is the thing, Deanna. The good news is this: since you are having regular cycles now, every 35 to 40 days, it feels like you can be pretty confident that the fertility pills are going to work with you or work for you without the addition of other things. However, there's one thing that you're sharing with me that makes me think, could we do a little bit better for you? And what I'm wondering is, with the symptoms of acne and hair growth, I'm wondering if your testosterone level might be high still. So maybe get your testosterone level checked and work on bringing that down before you start a cycle. I find my patients respond a lot better to their fertility pills if their testosterone level is normal. And I also feel if you have a high testosterone going into pregnancy, that might put you at higher risk for other complications in pregnancy. The list is pretty short list. So if your testosterone's high, for example, perhaps you might be at higher risk of having, let's say, diabetes in pregnancy. Or you might be having a higher risk, unfortunately, of having a baby that might be affected with autism. So that is something that studies have shown. And so I actually ask my PCOS patients to take Ovasitol, Ovasitol. And again, this is medical education, information, and not advice. So talk to your doctor. But there are studies that have shown that supplements like inositol, myo-inositol have been shown to decrease the risk of gestational diabetes in pregnancy. And also, since they decrease testosterone pre-pregnancy, for me and my patients, it's been a really good way to make sure their testosterone levels stay low throughout pregnancy too. So we don't have to worry about the complications. And we have we're being proactive, so to speak. This next question comes from Alice. Alice says, "Hi, Dr. Amy. I'm 35 and my hubs and I have been trying for our third child for over a year. We conceived easily and naturally with baby 1 and 2, and after seeking help, we found out I have severe DOR. My AMH is 0.1, FSH is 17, AFC is 5. I also found out I have a huge polyp. When the polyp was removed, I got pregnant quickly, but it ended in a miscarriage. I found out I was pregnant again only 2 weeks after my miscarriage, but that also ended in a miscarriage. Both were most likely blighted ovums. My hubs and I have both done all the genetic and chromosomal testing, and everything is normal. My question is this. Do I even bother with IVF? We've always wanted 4 kids, but seems like we might not get any embryos. Should we do letrozole and try naturally? I was told DOR is just about quantity, not quality. I'm worried all my eggs are bad. Why do I have DOR? I have a normal BMI. I'm an athlete, non-smoker, normal period since I'm 13. Update, second miscarriage came back as chromosomally normal, and I tested high for anticardiolipin antibodies. What is your special sauce for me? Alice, I love it. Let me tell you what my special sauce is. And a 35-year-old who wants 4 kids, I get super excited. I'm like, I want you to have 4 kids. I do. I want you to, like anyone who wants to be a parent that badly, to do what you're doing and to put your body through all of that, like you should, because I know that you are going to be an amazing mom to 2 more children. And if I can help you reach that goal and you're only 35, I would say, let's do it. I am so glad that you had your pregnancy chromosomally analyzed. I'm not really sure that's a technology. How about genetically tested? And finding out that the chromosomes were normal is so informative, because when I have a patient who's had a pregnancy that stopped growing, I want to know why. Why? Because if it's normal, I do this workup. If it's abnormal, I do this workup. If I don't know, I do both, right? And so you did the workup that's appropriate for someone who has had a pregnancy that ended because even though the chromosomes were normal. And what you learned is the A of the angel workup is the autoimmune stuff, and that's the antiphospholipid antibody syndrome, and you have the anticardiolipin antibodies. So I wish I could say like that should be an easy fix and you take aspirin and Lovenox and everything will be fine. But the answer is that your AMH level is about quality and quantity. Okay, so when the AMH level is less than 0.6, it is a reflection of not just how many eggs you have left, but also the quality of them, especially since you're 35. So I know it sounds silly. You're young. Like, why would this happen to you? And the answer is because you're 35, okay? And that's really hard to hear for all the other 35-year-olds out there. You're like, what, me? But for a lot of people, the P word, I'm not going to say it too loud, but it's perimenopause. And I don't like saying it too loud, but that's why I do these shows, to educate you guys about getting your levels checked over time. One of my Egg Whisperer golden rules is at your postpartum visit, when your doctor is like, what are you going to use for birth control pills? You're going to say, I'd like my AMH level checked, please, so that you're not in the situation of wanting 4 kids, finding out after the second that you now have decreased ovarian reserve. So the other things that I like to say, it's always nice to have eggs on ice. It's always nice to have embryos on ice, especially during a pandemic. Those kinds of rules would protect people like you from being in this situation. But that doesn't really help you right now, so I'm going to help you right now. So I'm super excited that you have 5 follicles. That's pretty amazing. I'm also wondering if the anticardiolipin antibody diagnosis might be a false positive, and if the chromosome analysis wasn't done with a certain technique or technology, they might have also detected your own DNA. So it's kind of like triggering to find out what the gender was of the pregnancy, but look at the technology that they used as you are learning more about what to do next. Okay, if you were a patient of mine, I would start embryo banking. That's what I would do. Because you said to me you wanted 4 kids, I would do what I can to help you with that. I would have you take all the egg quality supplements that I'm always talking about, the CoQ10, the NAD. Take your prenatal vitamin with fish oil and vitamin D, for example, and then start tracking and trending your levels and ride the wave, a good wave of eggs to retrieval. So with your next period start, get your FSH, estradiol, AMH checked, go back in for a follicle count, and if that looks like a good cycle, then go for it. Since you have 5 follicles, the right approach, I think in that case, it's the approach I would use, is a mini IVF approach to get a maxi number of eggs. So it's a combination of fertility pills and injections, and I also introduce HGH. Either now, a month before you start your cycle, or within your cycle, and you can take it every other day during stim. So that's what I would do. I would have no hesitation about offering someone like you with 5 follicles at your young age of 35 IVF. I wouldn't. However, if you're like, I just don't want to do that, I totally get it, then I would be more aggressive with stimulating your ovaries to help you ovulate more than 1 egg. Because if it seems like egg quality could be an issue, which I know your last pregnancy came back as genetically normal, however, I still think even in a case like that, it would make sense to see if we can help you ovulate maybe 2 eggs, sometimes even 3, to give you the highest chance of having one healthy pregnancy continue to grow. If you're a patient of mine, I have you take aspirin daily and take Lovenox after ovulation. I know there are a lot of different protocols for Lovenox. I ask my patients to take it 3 days after ovulation through, and in your case, if you truly have antiphospholipid antibody syndrome, it would be even through the 3rd trimester. So talk to your doctor more about all these suggestions. Go see an IVF doctor. It sounds like you've already talked to one, and see what you think about doing that. And then if you're not comfortable with doing IVF, I think that's okay too. But at the same time, I don't want you to miss out on an opportunity to freeze embryos for your future and give yourself the chance to have 4 kids. This next question is from Maddie. Maddie says, hi, Dr. Amy, I'm good to go from my end. I like that confidence, but my husband has a total sperm count of 16 million, 2% normal morphology, 9% rapid motility, and 75% are not moving. Are we looking at IUI or IVF at this point? Maddie, right at this point, we are looking at IVF. It's really hard to get pregnant when the sperm isn't moving fast. And when 25% are motile, it's really hard to get pregnant at home. It's really hard to get pregnant with IUI. It's really hard to get pregnant. But this is the thing. Sperm, they can have bad days. So just because he had a bad day on that day when it was analyzed doesn't mean that every day is going to be a bad day. Maybe he was super nervous. That can affect sperm quality. Maybe there was someone like knocking on the door as he was collecting. That happens. I've heard stories of people like having windows in the sperm collection room and people peeking in. Awkward. Or walking into a public stall just with doors and people are walking in and out going pee. Super awkward. So let's get him a home collection kit. So meetfellow.com/egg-whisperer, easy way to get your sperm checked. The results don't come to me at all. So you can use that site to get a DIY semen analysis done. Let's look again. And then remember, we want to know what we can do to make the sperm sparkle. We want that sperm to be amazing if you end up needing IVF, right? So we want to look at, is there a varicocele? Is the DNA of the sperm good? So do the sperm DNA fragmentation test. You know, what lifestyle is he leading right now? Is he smoking a lot of weed? Is he chewing tobacco? Is he day drinking? You know, cut that out, okay? Cut that out and wait about 2 to 3 months because it sounds like everything is fine on your end, and then repeat everything, and then who knows? Maybe you get pregnant without anybody's help. That's way more fun and way less expensive, way less involved. And I know it's not something that everybody can do, but if you have it in your power to do those changes and maybe they'll help, then I would go for it. This next question comes from Katie. Okay, let's see what Katie has to say. Katie says, hi, Dr. Amy, thank you for all you do. My husband and I are both 26. We're pursuing IVF with Hsg due to male factor infertility, varicocele resulting in low motility morphology. I have no known issues. AMH of 17, AFC of 20 on one side, 18 on the other, maybe slight PCOS. My BMI is 20.5, no hirsutism. My hemoglobin A1C is normal. Do you suggest we PGTA test? Our doctor didn't recommend it due to my age, but I can't shake that 30 to 40% of my eggs could be abnormal, putting us at a chance for miscarriage and heartbreak. Thank you so much for your advice and for answering our questions. Okay, Katie, here's the deal. You're a young woman. It is normal to have a high AMH if you're a young woman. Just because you have a high AMH and a high follicle count does not mean there's something wrong with you. I know when you go to Google and you're like AMH of 7, then all of a sudden it's like PCOS, bad eggs, all the stuff that comes along with that online. And all of a sudden those messages come into your head and you're like always negative thoughts. You just got to push them out of your head and remember, I'm young. It's normal to have a lot of eggs. So don't label yourself with anything or anything at all. However, I want to know why you're not removing the varicocele. Why? Okay, if the DNA fragmentation is good from the sperm, then I would say do IVF if you're feeling like I don't really want to wait another 6 to 9 months for the sperm data to get better. But if you're like, oh, I can wait 6 to 9 months and then try naturally and avoid IVF, then let's get the varicocele fixed. You know the diagnosis. The diagnosis is there's a varicocele, so why not remove it? That's what I would recommend to you if it were me. And at least removing it now, even if you end up doing IVF, could mean getting pregnant naturally for future babies and not having to do IVF for your next transfers, or next kid. So that's what I would be thinking about. The other thing about PGTA is this. It is the murkiest crystal ball. It is not perfect. We are only looking at chromosomes. But the thing is, I think sometimes it's nice for people to know when they're ready to have another baby, that they're picking an embryo that has the highest chance out of the batch that will stick and grow. So that's what PGTA can do for you. It is very accurate. I know a lot of people are like, it's not accurate. It's, people are throwing away abnormal embryos. And I'm like, no, I mean, if you're working with a clinic that's going to be honest and transparent and give you all the data about your embryos, and you can then choose and rank them and be given the option to transfer, let's say, mosaic embryos, it's a really good option. But if you didn't know what your clinic's rules were about transferring mosaic embryos and their protocol for reporting mosaicism, you might be, potentially, not transferring embryos or discarding embryos that could potentially be useful in the future. So, Katie, sign up for my IVF class, okay? I hope to see you there in 2 weeks. Go through ballsmethod.com, see a fertility urologist, have your husband do that. Look at his testosterone level, for example, too, and see if perhaps taking drugs like Clomid or Imidex or something like that could help him. And then get him on all the supplements and do the DNA fragmentation test first before you go into your IVF cycle. You don't want to go through all that physically with all the eggs that you have and then find out that you should have done all this stuff first. And then perhaps do more genetic testing if you haven't already. And then make sure you have the answers to this question, or the answer. It's going to be a long list of stuff. Ask your doctor, doctor, I'm 26 years old. I got a lot of eggs. What are you going to do to keep me safe? I don't want to have severe OHSS. So make sure they have a plan for you. And I'll just tell you what my plan is for my patients in your case. I see you a lot. We become fast friends. You see all my outfits. Guys, I only have one outfit. I have black scrubs. I have a ton of them, and that's all. But I just joke that you're going to see all my outfits. And see all my hairdos. My hair is always in a ponytail. And see all my lipsticks. You don't, because I'm wearing a mask. And hear all my jokes. I do come up with jokes every single day. That's very, very true. But as far as the OHSS protocol, it would be starting you at a really low dose after 2 days of injections, checking an estradiol level before you take your third night of shots. Then, depending on that third level, tell you what to do that night, or that day 3 level, and then bring you in on day 4. And then see you a whole bunch, titrating the dose as needed to make sure that we keep you safe. And then at trigger shot time, using only Lupron, and then also adding in medications like Fumarin, bromocriptine, and whey protein, and even ganirelix after the trigger shot. Those kinds of things can really, really help prevent severe OHSS in young people with lots and lots of eggs. Okay, this next question is from Natalie. Natalie says, I just started seeing a fertility specialist, and I've been told that I have PCOS, but my specialist isn't convinced that I have it. I'm 5'2", 110. My symptoms are this: irregular, absent periods, and polycystic appearing ovaries. I had a chemical pregnancy in July that was conceived naturally. After that, I was put on letrozole by my OBGYN in August, and it was 2.5 milligrams. I ovulated on day 13, but no pregnancy. I was on letrozole 3 more cycles and did not ovulate, even when I was bumped up to 5 milligrams. My follicle scan came back with my OBGYN showing little to no follicle growth. My AMH came back at 16. My fertility specialist wants me on letrozole 7.5 milligrams this next cycle, and he wants to do an ultrasound on day 12 to see how my ovaries respond. Do you think myo-inositol or CoQ10 will help with egg quality? Do you have any other suggestions that will help me conceive? Natalie, I should call it the Amy PCOS protocol. I should. Here's what you do. 1. Heal your PCOS. Look at all your hormone levels and balance them. Take supplements like NAC, lipoic acid, ovasitol, CoQ10. Look at your vitamin D, make sure it's normal. Look at your TSH, make sure it's normal. Look at your prolactin, make sure it's normal. Testosterone, if it's not normal, take the time to normalize it. 3 different ways of doing it, aside from the supplements I just mentioned. Way 1, birth control pills. You're like, what? Yes. Birth control pills are PCOS testosterone lowering pills. I just came up with that right now. They actually do that. They lower testosterone. It does it really, really well. And then what you could do is also add in spironolactone, add in metformin, and then I would check your testosterone maybe 3 weeks, 4 weeks after you start these medications. You can always start 1, check your hormone levels, then see where you're at with your testosterone. If you still need more work on it, then wait another 2 to 3 weeks, bring in, let's say, spironolactone or metformin. You know what I mean? You can do things in a stepwise approach. Talk to your doctor about the side effects of all these medications because they're not side effect free. For example, birth control pills. Some people get really moody on them. Spironolactone, I don't really have patients that describe any bad side effects from them. Metformin, let's just say you might get a little crampy in your stomach and might have some GI issues, like maybe you need a separate toilet from anyone else in the house. You know what I'm saying. But I often will use naltrexone, low dose, with dexamethasone, with the fertility pills, after I've balanced all the hormones out to see what we get. And then there are different protocols that you can use. You can do Femara. You can do Femara for 5 days, 10 days. You can even overlap and take Clomid with Femara. I know, blowing your mind right now. There are a lot of creative ways to help someone just like you achieve an ovulation, and I assume your doctor has done all the genetic screens already, looking at, for example, CAH. Okay, this next question is from Gurpreet. Gurpreet says, hi, Dr. Amy. Thank you for spreading the awareness regarding fertility issues. Background, I've been trying to conceive since last year. My fertility doctor recommended the Hsg. Here's what happened. I went 3 times. The doctor could not perform the test because of my fear and anxiety. My doctor recommended that I should take strong anxiety medication, but I was not still letting them do the test. My question is this: is there any place in the U.S. where doctors perform HSGs under anesthesia with IV sedation? Will you be able to request an HSG test for me under IV sedation or anesthesia? Because of this issue, I am stuck in my fertility journey. Please help me. Thank you. Okay, Gurpreet, here's my question to you. If you can't tolerate an HSG with lots and lots of drugs relaxing you, how's your sex life, right? So I wonder, the HSG might be a sign of what's really going on. Are you really, is the penis, I know, this is what I talk about every day, all day. Is the penis really getting to the top of the vagina? Right? And if it's not, perhaps just going right to IVF and taking the baby making out of the bedroom might be the simplest option for you. And then you can say, I'm okay without the HSG. But to answer your question, the answer is yes. There are fertility centers here in the Bay Area that have the HSG equipment, and they can just roll it right into the operating room, and you can have the HSG while you're asleep. It is possible. So it's possible at centers here, and I'm happy to help you. You can send me a message through my website. There's a contact page there if you guys want to consult. If you have a question and I can help you, that's the best way to reach me, okay? This next question comes from Chaden. Chaden says, hello, Dr. Amy. Thank you for your advice on enhancing my egg quality. After 8 cycles, 8. You get an award, Chaden. That's persistence right there. That's like warrior status. You guys all have warrior status, but that's pretty impressive. I have 4 frozen embryos now that I can transfer. I would like to be advised on supplements or lifestyle to increase my endometrial thickness to obtain a satisfactory implantation and pregnancy. I love that word, satisfactory. Okay, I would like to mention that a few days ago, my embryo transfer was canceled because my lining was 5.5 millimeters. I enormously would appreciate your feedback. Chaden, last week my word was ridiculously. Like, I'm ridiculously excited to get all your questions. I was ridiculously excited to help every single person walking through my door, ridiculously excited to do every single embryo transfer that I did. But now I'm going to change that word to enormously. I'm enormously excited to answer this question. Here's the deal. So I would look at the lining thickness on the day of your trigger shot with every single egg retrieval. Use that information to guide you. Ask your doctor, right? Sparkle checklist. The L is the lining. For those of you who don't know what I'm talking about, go to sparklemethod.com and you'll see the checklist that I'm referring to. If your lining was gorgeous, guess what? That's the protocol that you should use for transferring, right? If you're having a hard time transferring with the type of protocol that you're on, then let's learn from the lessons that you learned so far with your 8 IVF cycles and do like a stimulated embryo transfer cycle. If this were to happen to a patient of mine, I would say, look, it really sucks not to get to a transfer, but let me tell you, finding out that it didn't work is the worst. So I'll take canceling or rescheduling a transfer any day over doing a transfer and then finding out it didn't work. So I'm glad you didn't move forward. I'm glad you've decided to regroup and reconnect and send me this question. So I would also consider doing a hysteroscopy or saline sonogram if not done already. Look for scarring. I worry about people who might have a thin lining and the damage that doing a biopsy could potentially do to them. So I don't necessarily recommend the ERA and Receptiva DX test for everybody, but it might still be something that you consider. Okay, so talk to your doctor about that. You worked so hard for these 4 embryos. I certainly don't want you to be in a situation where you would have wished someone had offered you that test. Few other things. 3, L-arginine, vitamin E, and aspirin. That's something that I give everybody. And then there are different modes of administration of the estrogen. So there's the Vivel patch, there's the estrogen shot, and then there are estrogen pills that you can take either orally or vaginally, right? Back to the Pharmgina, pharmgina.com. Not a website, just something that makes me crack up every time I say it. Pharm, P-H-A-R-M, Gina like vagina. Yes, it's not even Friday, and I'm this funny, and it's Wednesday. I know. It's hard to, like, not be embarrassed for me, but it's okay. My husband's already embarrassed enough. Before you even, let's say, go to a medicated cycle, sometimes it's actually easier to coordinate your life. I'm sorry, before you go to a natural cycle or stimulated transfer, it's sometimes easier to coordinate things with your life if you're doing a medicated cycle. So maybe just start over, try the estrogen shot, and see what happens. And hopefully all you're going to see is a gorgeous lining. But for people who are considered an IVF challenge to their doctor, there are lots of other things that you can do for a thin lining. Your doctor will know all of those things, but some of the things that I've done successfully would be to use HBOT or hyperbaric oxygen therapy or a tank, where patients go in for the first 5 days of starting estrogen. And for some reason, well, not for some reason, there obviously is a scientific reason why it can work for some people. Some doctors have found success with adding medications like tamoxifen. Other doctors have found success with injecting PRP or platelet-rich plasma into the lining. So those are different suggestions that might help you. So thank you guys for being here on Ask the Egg Whisperer. Thank you for listening and watching and tuning in with each episode. I really hope that the questions that I'm answering are helping you. Even if you're like, oh wow, I'm just starting my journey and she's just saying a whole bunch of things that I don't understand, that's okay. By hearing other people's stories, it hopefully makes you feel a lot less lonely, knowing that there are other people around you that are going through the same thing. So thank you. So now I'm going to get to your live chatted questions. You guys probably thought that I was going to sign off, but I'm not going to. So let's just see what you guys are live chatting right now. And let's do this. Here we go. Odds of seeing a fetal heartbeat at 5 weeks, 6 days. HCG is 3,243 on 5 weeks, 4 days. So I would say your odds of seeing a heartbeat at 5 weeks, 6 days are probably around like 85%. If you don't, no big deal. I bring my patients back at 6 weeks, 3 days, and I'm like, that's when I expect to see it. If I don't, I get a little bummed out. And not just a little, a lot. Next question here from Annette. Annette says, does an embryo being PGS normal or embryo grade play a bigger role in implantation success rate? So the answer is having normal chromosomes is like very, very important. And then if you have an embryo that is good quality and it doesn't have normal chromosomes, that would not be an embryo that I would choose to transfer. So I hope that kind of answers your question. Gabrielle says, is a 1BB PGS normal embryo, does that have a good implantation rate? So in general, we don't biopsy 1BB. So ask your doctor, why did you choose to biopsy this 1BB? I do biopsy 2BBs. It just kind of depends on, how the trophectoderm looks on that embryo. But for the most part, think of a kernel and all the popcorn that comes out. We want all the popcorn to come out before we take a little biopsy and freeze that embryo. So in a 1BB, sometimes I worry that biopsying a 1BB could potentially damage the embryo. So be like, doctor, did you really biopsy a 1BB? And why? Otherwise, we like to wait for the popcorn to come out and then we biopsy it. And usually that's a 2BB or more. The number refers to, and I'm showing you the number, refers to how much popcorn is out of the kernel. And then the other letters refer to the quality of the cells that become the embryo and the quality of the cells that become the placenta. Next question is this. I'm concerned about blood clots going through IVF. My mom had a stroke at 56 years old and I had migraines with auras when I was on birth control. I would be too. So that's actually one of the questions I ask all my new patients. I say, any history of any family members who've had a stroke at an early age. So I would do a thrombophilia workup if you haven't already, and I would talk to your doctor about taking aspirin and making sure you're avoiding high estrogen, and also talk to your mom and your mom's doctors and see what did they discover as the predisposing factor to that stroke. Was it perhaps high blood pressure and had nothing to do with a blood clot? So if that's the case, make sure your blood pressure is also normal and you're doing all the things to minimize preeclampsia and pregnancy. So what are those things? A healthy BMI, so a BMI less than 30, normal triglyceride levels, a normal hemoglobin A1C, decreasing stress, and I'm sure there's a whole bunch of other things, but those are the big picture things that I think about. Next question is, should I take baby aspirin during stim for retrieval? I don't have my patients take aspirin during IVF stimulation phase. Next question from Amanda is, what do you suggest to lower elevated testosterone due to PCOS? Metformin is not working. My doctor doesn't seem to really care. Well, I care. I would consider just taking a break, going back on birth control pills, spironolactone, okay? And then you can stay on the metformin, but birth control pills and spironolactone work really, really well. Spironolactone will almost always work to reduce your testosterone levels. So if 25 milligrams isn't getting you there, go to 50, go to 75, you can even go to 100, but you have to watch for the side effects and look at your metabolic panel, looking at your sodium and potassium, and make sure that they're still normal. Next question, does slow growing follicles denote poor quality or not always? Do you have a max length of time that you let people stim for? So slow growing follicles can certainly be a sign of low egg quality, but it can also be a sign that your ovaries were too suppressed. You were very sensitive to the birth control, they're very sensitive to the estrogen priming, and just taking your ovaries a little while to sparkle and just come out of their shells, so to speak. So that could be one reason, but the reality is it could be a sign of lower egg quality. And I've stemmed people day 13, even day 16 before, to get really beautiful embryos still. So as long as my patients know what's going on, understand what things might mean for them, and we still feel like we're going to keep going, and then I'm happy, we keep going. But if I feel like things aren't going well, that the estrogen levels aren't rising the way I would expect them to, then I would be like, stop. Your ovaries are just telling us to walk away. Next question is, hi, Dr. Amy, does PGT test for Down syndrome and autism? Are there tests for these? So Down syndrome means an extra chromosome 21, and yes, PGT does test for that. It does not test for autism that's related to anything other than chromosomal abnormalities. So there's some microdeletions, for example, that can put you at risk for having a child with developmental delays and issues like that, like autism. However, in general, autism is multifactorial. It's likely related to a whole bunch of genes. There are probably over 100 genes, and we just can't necessarily test embryos for them. Next question is, I asked my doctor to add HGH for my next cycle. She was not enthused about it, but said she would do it at my request. She said she would add it during stim. Is that good enough? So I would say, yeah, it could be good enough. You don't necessarily need to start it before your stimulation to get an effect from it. Next question. Hi, Dr. A. What is your protocol for hyperbaric chamber? I'm trying new strategies to thicken the lining. What days in the cycle and for how long? Also, is it okay in early pregnancy to do HBOT? And the answer is no, we don't do it in pregnancy. I have my whole protocol that's all typed up on my letterhead. If you email me at eggwhisperer.com. I'd be happy to send my HBOT protocol. It's the same protocol that's been used in studies looking at thin linings, so you can look it up there on PubMed as well. Let's see here. Next question. My age is 30. My period is regular, always 25 days. We tried for pregnancy naturally since 1 year. IVF was done, but didn't work. My AMH is 0.5. Can I try IUI or should I go to IVF again with donor egg? So Sandy, that's a really personal question. If it were me, I would say try IUI, maybe try 3 to 6 cycles and see what happens, and then still have your donor egg all picked out. You can even reserve the donor egg because I really want you to have more than one baby if you don't have one already. So I've had patients who've gotten pregnant naturally even after they've chosen their donor, knowing that they want a big family. And they know in 2 or 3 years when they're ready for their second child, the quality won't be there, especially knowing the struggle that they had for the first baby. Next question from Sarah. Hi, Dr. Amy. I have PCOS and had severe OHSS. I had 35 eggs retrieved and only 1 was normal. Do you think my severe OHSS is part of why this may have happened? Sarah, that's a really, really hard question. I think it just really depends on how many mature eggs they got. I mean, if you had severe OHSS, maybe they triggered you early because they were worried about you and they didn't get many mature eggs. So the fact that you got 1 normal could have just been what was expected given the number of mature eggs that you got. So that's a really good question to ask your doctor, directly, but I don't necessarily know that I can answer it just as a yes or no. Next question from Ori says, I have multiple miscarriages with PGS tested embryos. ERA is normal. Hysteroscopy is normal. What would you suggest? The doctor does not want to change the protocol of Hashimoto's. So, or in a case like yours, I would consider the ERA test and the Receptiva DX test. I would do a hysteroscopy or some sort of cavity evaluation like the saline sonogram if you haven't done that already. If your doctor still will not do those tests, no big deal. Perhaps move forward with a different protocol as if something is wrong. And what I mean by that is perhaps try a protocol of using Depo-Lupron with Femara, as that has been shown to improve receptivity in the lining of the uterus and potentially in your case can help. I've seen it help before. Next question from Sheila. What should your progesterone levels be at 9 weeks pregnant? You know, I tell patients at least 10. I don't want people to worry that their progesterone's low when it's really not a problem. Sarah says, my doctor said there's no reason to measure progesterone in blood after the lining check prior to an embryo transfer because the serum level doesn't equate to levels in the uterus. Is that true? So I actually like to check progesterone because I feel like my patients are very intelligent. They like data and they want action to be taken if the action is needed. And we don't want to find out later that action could have been taken and action could have helped potentially prevent something like maybe things not working out. And then that feels like we could have done something differently. The reality is that for me and my patients, that progesterone does matter. I check progesterone at the lining check, okay? And for most of my patients, we have done a mock cycle. So I already know what their absorption is. I've already done the ERA cycle. On the day I do the biopsy after 6 days of progesterone, I've checked their progesterone levels, so I know what their absorption is. I check progesterone levels the day before a transfer if a patient is using endometrin. I check 4 days after a transfer if a patient is using endometrin or a vaginal suppository like Crenone or endometrin. I check progesterone levels. You see the theme here? I check them all. On the day of the Hsg check, meaning the pregnancy test, for patients who are doing progesterone and oil, and then I obviously also do it if you're using endometrin, and then I'm constantly checking the progesterone and titrating things after that. Brooklyn is saying, hi, love you for what you do. I have DOR. FSH is 12.5. I'm on my second IVF cycle. The first one we got 1 PGT tested embryo out of 16 eggs. For the second, I've been on all your recommended supplements, and the doctor is repeating the same protocol. For stem start on February 7th, we also have a 2.5-year-old. We want 2 more babies. We want more embryos to get 2 more babies. So it sounds like you're in good shape. That's pretty exciting. I would say that your FSH level is probably fluctuating. And I imagine that 12.5, probably the next time you check it, if you do, would probably be 10 or maybe even less. This next question says, having POI, so that's primary ovarian insufficiency for those of you guys who don't know what that is. My AFC was 6 last month, now 0. AMH is 0.2, FSH 8.7 and 14. I'm 34 years old, very painful periods, and I just found out that my uterus is anteverted and displaced laterally to the right. Could this be endometriosis? And the answer is it definitely could be. If you are symptomatic like that, I would strongly suggest seeing an endometriosis expert, but at the same time start banking your embryos. The thing is that endometriosis surgery, or I should say IVF medications and fertility drugs can stimulate more endometriosis and cause it to grow. So it's usually a good idea to do your IVF first, and then do the endometriosis surgery, and then transfer if your doctor agrees. This next question is from Aaron. Hi, thoughts on castor oil packs helping with fertility? I would say no. My thoughts are throw them away. Any thoughts or ideas? This is Brooklyn asking again. We're open to 2 more cycles. Yeah, so Brooklyn, I would take all the egg quality supplements that I'm always talking about. I would add HGH. I would ask your doctor what the sperm looked like on the day of the egg retrieval and see if there's anything that you could add to the technology that you're using in the lab. Get all your official reports together. It sounds like you got 1 PGT tested embryo that was normal, but make sure that they have a policy of being transparent and reporting mosaicism to you, so you're not discarding potentially normal embryos that have been labeled abnormal when they're really mosaic. So go to embryodiamonds.com and you'll see all the things that I want patients to know about their embryos, including the sperm reports. And then literally just say to your doctor, why do you think we should use the same protocol? Okay, so if you're a patient of mine and we got like 8 blastocysts and 1 was normal, I would be like, well, I couldn't have changed the normality, right? Like that was an amazing cycle. We got 8 blastocysts. The fact that 1 was normal, I don't think we should change the protocol. So it could be something like that. But if it was like you got only 1 blastocyst, then certainly it would make sense to consider other protocols and then ask your doctor why or why not in detail. Okay, next question is, I had my ERA and Receptiva test today. My lining was 19.7 millimeters. Is this thickness normal? My doctor wasn't concerned and said everything looked gorgeous. And the thing is this, your lining could have been totally gorgeous. Just because it's 19 millimeters doesn't mean there's anything wrong. I look at linings before the biopsy. So I look at the lining even before progesterone starts. And then sometimes the lining can continue to grow a lot faster than expected for patients who do the ERA test. But I would look at the length of time that you were on the estrogen. Perhaps next time you only need 10 days, right? And then if you aren't doing a lining check before you start progesterone, be sure to ask for one to look at the lining thickness and make sure you're not starting progesterone at a time that it is too thick. And when you have a really thick lining and you haven't already ruled out a uterine polyp, that's something that you should do, because sometimes the lining is super thick because of a polyp. So make sure you've talked to your doctor about ruling that out with a saline infusion sonogram. Next question is from Sarah. Can a longer downregulation cycle help with embryo quality? I have PCOS and endometriosis with a history of poor embryo quality, following 2 short cycle IVF protocols. Doctors recommending 2 months of Zoladex. Okay, so this is the thing. I would strongly suggest reconsidering taking Zoladex. For those of you guys who don't know what Zoladex is, in this country, in the US, it's Depo-Lupron. It's a medication that can suppress your ovaries greatly. And so if you already have a history of PCOS, endometriosis, and poor embryo quality, I really worry about suppressing you too much and then delaying things too long, and maybe your body will just take too long to wake up. So that would be my concern around that. I would consider other protocols to wake your ovaries up and get beautiful embryos. Talk to your doctor about what it takes to get better embryo quality, and you guys know what that means. An embryo is sperm and egg, and we have to look at age, right? Age, genetics, and environment for both. So talk to your doctor about what things you can do to get the eggs to sparkle, the sperm to sparkle, so that your embryos sparkle. Next question is, Dr. A, I've done several IUIs, and it turns out that I recruit a lead follicle very early. Now thinking about IVF, would this knowledge inform choice of IVF protocol? And the answer is yes. So for you, Allie, I would have you go in early to see your doctor. Maybe it's treatment day 3 or 4, so you can add the antagonist early. You might be someone who could benefit from just a whiff of estrogen priming, right? So just 3 days of estrogen before you start your stimulation. So that would be a case where estrogen priming could really play a good role. The other thing that you might want to consider, if you recruit super early, like you go in for your baseline and then all of a sudden you have like a 14 millimeter follicle, you could be a good candidate for a mid-luteal phase start. So I hope all of these tips are going to help you. Next question is, can high prolactin level affect IVF? We have male factor infertility. My doctor determined my prolactin level around between 29, 122, and 43. I've had 3 checked, but is not concerned. Other hormones are okay. Should it be fixed before IVF? So I would say check it again. I mean, it sounds like 29, 122, 43. It sounds like it's kind of bouncing all over the place, and that could be because of where you were in your cycle. So check it again, and if it's still high, let's say over 50, it does make sense to treat it for me. Treating it can happen very quickly. It doesn't take a lot of time to bring down a prolactin level. Using bromocriptine, for example, as a medication can really be helpful, and seeing a medical endocrinologist to work that up completely would be great. This next question is, let's see here, you guys are adorable. What antidepressants don't affect sperm? We're going through IVF and my partner feels like he would benefit from being on an antidepressant, but I'm afraid. So as far as antidepressants go, I always want to ask, why is he feeling this way? Could it be a sign of low testosterone, low vitamin D, a thyroid abnormality? I think before we start talking about antidepressants, it's really important to talk about other possible causes of feeling this way, because those causes can also affect sperm quality. So if the testosterone is low and it's causing depression, then you can imagine that the sperm will be low too. And so if you fix the testosterone level by taking medications, not testosterone, to improve testosterone like Clomid or Arimidex, that will improve your mood, improve your depression, and voila, improve your sperm. Next question. Is it more common than not to feel pregnancy symptoms after an FET during the 2-week wait? And I would say that most patients feel nothing. When I call a patient and tell her that she's pregnant, she's like, are you sure? I feel nothing. Like I have to convince patients. They're like, is this a joke? I'm like, trust me, there are things that I joke about. This is not one of them. Like, I'm not joking. You are pregnant. So as far as prenatal vitamins that I recommend, so Ferranatal is one brand. You can use the PRC code TUSHY, all caps, TUSHY for the PRC price. Someone's asking, is the Hsg test painful? And the answer is the Hsg test can be very painful. Some people describe it as the worst pain in their lives. I actually have a podcast and a blog article, and I think it is titled How to Survive the HSG. So go to my Dr. Amy website, draimee.org, look for the search sign, type in How to Survive HSG, and voila, you'll see a video, you'll read an article, and I give you all the tips on how to survive. Okay, guys, I'm going to sign off now. It has been a pleasure being here tonight and answering your questions. I have trigger instructions that I need to review, a few more phone calls I need to make. So I'm going to leave now, and I look forward to seeing you again, probably pretty soon. I know. Don't be surprised. You're not surprised. So I love you all. I hope you guys have a really great night, and I look forward to getting your questions and interacting with you in this incredibly special way. So thank you guys for being the warriors that you are. It is so worth it. And remember, you're going to be a mother one way or another. And go to my last Instagram post about what I just said, and you're going to find all the mantras that people have added in there. And if you haven't added your own, add it. I think it's a pretty cool collection for other people to see in the future as far as what you guys do to build yourselves up when you're feeling down. So thanks, guys. Have a great night. See you soon.